Welcome to the deep dive. Today we're tackling something pretty fundamental to healthcare, but maybe a bit behind the scenes, medical coding.
Yeah, it's definitely behind the scenes until you get that bill right.
Yeah.
We're going to unpack the ICD-10 system.
Exactly. What it is, why it's so important, and how it actually works day to day.
Think of it as the universal translator for healthcare. It takes all these complex diagnoses and procedures and puts them into a standard language.
And that's not just for billing, is it? Our sources stressed it's much bigger than that.
Oh, absolutely. It's critical for tracking diseases, spotting public health trends, even guiding research. It affects, pretty much everything.
Okay, ICD-10 sounds quite technical, maybe recent. But you mentioned it actually goes way back, like almost 100 years.
It does, yeah.
Yeah.
Surprising, isn't it? The very first version popped up back in the 1930s.
Wow.
And back then, its job was really specific.
Yeah.
Just classifying the cause of death, purely mortality statistics.
Just cause of death. That's
Yeah.
a narrow focus compared to now.
It really is.
Yeah.
It's fascinating how that initial need, just tracking why people died, ballooned into this massive system we use today for, everything health-related.
So what drove that change? How did it go from death stats to diagnoses?
Well, as medicine got more sophisticated over the decades, doctors needed better ways to classify, illnesses and other health problems, not just the final outcome.
Right.
So by the 1970s, the International Classification of Diseases expanded hugely. It started including actual diagnoses, symptoms, all sorts of health information.
Which gives a much richer picture, I guess.
Exactly. Imagine trying to track, say, a flu outbreak with only death records versus having detailed codes for everyone diagnosed. Big difference in understanding.
Makes total sense. And now we're on the 10th revision, hence ICD-10. But I think I read something about ICD-11. Is that coming soon?
Yes and no. ICD-11 is approved internationally. It's more modern, more detailed.
Oh.
But switching over is a massive job for the whole U.S. healthcare system. Think about retraining everyone,
Yeah.
updating all the software.
Okay, yeah. Huge undertaking.
So realistically, widespread adoption here in the States. It's
Yeah.
not expected anytime soon. It'll
Yeah,
happen
yeah.
eventually, but not yet.
So for now, it's ICD-10. But even that isn't just one single thing in the U.S., is it? Our sources mention different versions.
That's a really key point, yeah. While the core is international, the U.S. uses specific modifications.
So modifications, okay.
For your regular doctor visit, the code used for billing, that's professional billing, comes from ICD-10-CM. The CM stands for clinical modification.
Okay, CM for clinical settings, and the other one.
If you're admitted to a hospital, the hospital facility uses a different system for coding the procedures they perform. That's ICD-10-PCS, Procedure Coding System.
Right, so CM for diagnoses, PCS for inpatient procedures. Good distinction.
Crucial distinction, yeah. Different books, different rules, different purposes.
So for the deep dive, we're going to focus on the CM side, ICD-10-CM, the one you'd see on a doctor's bill or used for diagnosis coding.
Exactly. We'll use our sources to figure out how you actually navigate that ICD-10-CM book
Yeah.
to find the right code. It can seem pretty intimidating at first.
Like a giant medical dictionary, maybe? So if we open up this ICD-10-CM book, what are the main sections we need to know about?
Okay, think of it like a reference manual. Right up front, you've got the coding conventions, kind of the basic rules of the road for the whole system.
Inventions. Got it.
Then, super important, are the official ICD-10-CM guidelines for coding and reporting. These are like the law. You have to follow them.
And they're easy to find.
Yep, they're usually right after the conventions. And critically, relevant sections are also placed at the start of each chapter in the main part of the book. So the rules are close to the codes they apply to.
Okay, that's handy. Rules and guidelines first. What else?
Then you hit the main index, the index to diseases and injuries. It's alphabetical. That's usually your starting point when you have a diagnosis.
The alphabetical index,
Mm-hmm.
like the back of a textbook.
Sort of, yeah. But instead of page numbers, it points you towards potential codes in the next big section, the tabular list.
Okay, but before the tabular list, there are some other tables.
Right. There are a few specialized tables for specific things. There's a table of neoplasms, that's for cancers, a table of drugs and chemicals for poisonings or bad reactions to meds, and an index to external causes of injuries that helps classify how an injury happened. Like, was it a fall, a car accident, things like that.
Specialized indexes. Makes sense. And then the big one, the tabular list.
Exactly. The tabular list, that's the core of the book, organized alphanumerically by code. It lists every single code, But crucially, it also includes detailed instructions, definitions, notes, everything you need to confirm you have the right code.
So index points the way, tabular list confirms the destination and gives you the details.
That's a perfect way to put it.
Okay, let's try a simple example. Say a patient comes in and they just say they have a cough. Where do we start the coding process?
First step, always, is to nail down the main reason for the visit. Why are they seeking care today? In your example, it's the cough. Seems simple, but getting that primary reason right is fundamental.
But what if that's all we know? Like, the doctor hasn't figured out why they're coughing yet. It's not bronchitis or pneumonia, just a cough.
That's a super common situation. And the rule is, you code what you know at that time. If a definitive diagnosis isn't established, you code the symptom.
So you'd literally just find the code for cough.
Precisely. You don't guess, you don't assume. If cough is the documented reason, you code cough.
Okay. So we've identified cough, now we need the code. We go to that alphabetic index, right?
Yep, index to diseases and injuries. For a single word thing like cough, it's pretty straightforward. You just look up C for cough.
Almost like a dictionary lookup then.
Pretty much. For those simple ones, it'll point you towards a code, or maybe a range of codes, in the tabular list.
But what about something more complex? Our sources used urinary tract infection. You wouldn't look under U for urinary, would you? That feels inefficient.
You're absolutely right. That's where the concept of the main term comes in. It's usually the condition or the disease itself, not necessarily the body part or an adjective describing it.
So for urinary tract infection, the main term isn't urinary or tract.
Nope. The main term is infection. That's the core condition.
Okay.
So you'd go to I for infection in the alphabetic index. Then you look at the indented terms listed underneath infection until you find urinary tract.
Ah, like an outline. Main term, then subterms getting more specific.
Exactly. It's hierarchical.
And what about those C condition notes? What do they do?
C condition. That's a signpost in the index. It tells you, don't look up the body part itself as the main term. Instead, look up the problem with that body part.
Can you give an example?
Sure. If you have, say, pancreatitis, you wouldn't look up pancreas. The index might say pancreas C condition. That tells you to look up the condition, like inflammation or infection or whatever the actual issue is affecting the pancreas.
Okay, that clears it up. Code the problem, not just the location. So when we're in that alphabetic index, looking at main terms and subterms, what other little details should we watch out for?
Good question. Pay attention to any specific instructions within the index itself. Also, you'll see words in parentheses sometimes.
Parentheses?
Yeah, those are called non-essential modifiers. They're descriptive words that might be documented, but they don't actually change the code assignment. They just add context.
Okay. Anything else?
Definitely look for See Also notes. They might point you to related codes you should consider. And be aware of abbreviations like NEC.
NEC.
Not elsewhere classified. That means the doctor documented something quite specific, but there isn't a unique code for that exact level of detail in the system. It's a way to show specificity when a perfect code doesn't exist.
All right. So we navigate the index, find a potential code. Say, for hypertension, we find I-10. Are we done? Can we just write that down?
No, absolutely not. This is probably the most critical step people miss. You must take that code you found in the index I-10 in your example and look it up in the tabular list.
Always verify in the tabular list. Why is that so important?
Because the tabular list gives you the full picture. It has the official code description, defines what's included or excluded under that code, and lists any other instructions or guidelines that apply specifically to I-10 or codes around it. The index is just a pointer. The tabular list is the final authority.
So even if I-10 in the index looks perfect for hypertension, I still have to flip to the I chapter in the tabular list, find I-10, and read everything around it.
Everything. You need to confirm it's the right code, see if there are more specific subcodes maybe, check for any code first, or use additional code notes. It's non-negotiable.
Which brings us back to those official guidelines you mentioned earlier. They're key throughout this whole process, aren't they?
Foundational. Absolutely essential. You might not memorize every single guideline. There are a lot, but you need to know they exist, generally what they cover, and where to find them when you need them.
And the books helpfully put them at the start of each chapter in the tabular list.
That's the standard layout, yeah. So if you're coding, say, a circulatory issue in Chapter 9, the specific guidelines for Chapter 9 codes are right there at the beginning. Keeps things organized.
Okay. So index, potential code, DAF, verify, and tabular bad check guidelines. What happens next, assuming the code checks out?
Okay, final steps. You confirm the code is the best fit based on the documentation, and the tabular list info. Then you assign it. But if there's more than one condition,
Ah, right, multiple diagnoses.
then you have to think about sequencing. The order you list the codes matters.
Why does the order matter?
It tells the story of the encounter, basically. It impacts billing, statistics. The guidelines tell you how to sequence. Sometimes you'll see a code first note in the tabular list, meaning an underlying cause needs to be listed before the code you found. Or you might see code also, meaning you should add another related code to give the full picture.
And what about things like acute versus chronic? Our sources mention that.
Yeah, that's a common sequencing rule. Generally, you sequence the acute condition before the chronic one. So if the diagnosis is acute on chronic kidney disease,
You'd list the code for the acute kidney problem first.
exactly, followed by the code for the chronic kidney disease, it prioritizes the most immediate issue. And again, all these rules are spelled out in those official guidelines.
Okay, this is starting to form a clearer picture. Let's just quickly revisit main terms with a few more rapid-fire examples. Ruptured ovarian cyst.
Main term is cyst. You'd look under cyst, then ovarian, then ruptured.
Got it. Abdominal pain.
Main term is pain. Then look for the subterm abdominal.
Makes sense. Chronic sinusitis.
Main term, sinusitis. Chronic is a subterm modifier.
Okay. And febrile convulsions.
Main term is convulsions. Febrile describes the type, so it's a subterm.
Great. Those help solidify it. Could we try walking through one complete example, start to finish? Like upper respiratory infection, a really common one, often just written as URI.
Sure, perfect example. Okay, upper respiratory infection, first step, main term.
Infection.
Bingo. So open the book to the alphabetic index, find infection.
Okay, under I for infection, now I look for...
Scan the indented subterms under infection.
Right.
You're looking for respiratory.
Respiratory, and under that?
Look for upper. You might even see something like upper acute listed there.
Okay, yeah. Upper and next to it or under it, I say J06.9.
J06.9. That's our potential code from the index. Notice there might be other indented options under upper, like chronic, streptococcal, viral, but if the note just says URI or upper respiratory infection.
We don't have that extra detail. So J06.9 looks like the best fit from the index for an unspecified URI.
Seems like it. But what's the next absolutely critical step?
Don't just write it down. Go to the tabular list.
Exactly. Flip over to the J chapter in the tabular list and find J06.9.
Okay. Finding J06. Here it is. The category J06 says acute upper respiratory infections of multiple and unspecified sites.
Good. Now look specifically at J06.9.
J06.9 description is acute upper respiratory infection unspecified. That looks like exactly what we need.
Perfect match for a simple URI. Now look carefully around the J06 category description or J06.9 itself. Are there any notes? Like use additional code or anything?
Let me see. Yeah. Under J06, it says use additional code to identify infectious agent.
Okay, but does it say if known or something similar?
Yes, it does imply that identify infectious agent, B95, B97. It doesn't say you must add one.
Right, so if the doctor just wrote URI and didn't specify if it was, say, RSV or strep, do we add another code?
No, because the agent isn't identified in the documentation, so we just stick with J06.9.
Precisely. You followed the process index to get the potential code, then tabular list to verify the description and check for any instructions. And in this case, for an unspecified URI, G06.9 is the final answer.
Well, that walkthrough really helps connect the dots. It seems the key takeaway is you need to understand the book's layout, really focus on finding that correct main term in the index, but never skip verifying everything in the tabular list and checking those guidelines.
That's the core loop, absolutely. Index, then tabular, always checking guidelines. It seems complex, maybe a bit rigid, but it's essential for making sure everyone's speaking the same language in healthcare, for billing, for tracking disease, for everything.
It really is a fascinating system when you unpack it. It makes you think about how we try to categorize, well, everything about human health. This detailed classification. It reflects this ongoing quest to understand the body and its problems.
It does. And you have to wonder, with medical knowledge advancing so fast, with AI and everything else, what will the next generation of these coding systems look like? How will we classify health and disease in the future?
That's definitely something to think about. A very provocative thought to end on.
Always more to explore.
Thanks for joining us for this deep dive. We'll see you next time.